We are live now.
Thank you, Mr. Abhishek. So, do we start, ma'am, now? Um, अभिषेक जी क्या हम स्टार्ट करें?
Yes, ma'am. We are good to
Okay,
go.
okay. A great good afternoon to all the august luminaries of North India Gynecologist Forum. Today is a day of celebration for two reasons. Firstly, my heartiest congratulations to Mrs. Draupadi Murmu, who has been elected as our 15th president with overwhelming majority. This is a true ode to womanhood in India and fills us with immense pride. Secondly, I congratulate all for the successful launch of N.I.G.F, that is North India Gynecologist Forum, on 20th of July 2022. Today is the launch of academic activities for this very prestigious professional body, that is NIGF. We will be having two meetings every month on first and third Friday between 4 to 6 p.m. as today. So I would humbly request all of you to please block your dates for the same. And I assure that the richness of the content of these meetings will bowl you over. The primary aim of these interactions would be first, sharpening and upgrading our skills through information and knowledge sharing. Academic excellence would be the cornerstone of these interactions. Secondly, promoting the unity of gynecologists of Northern India, and also to provide a platform for interacting with each other and building new friendships. My mentor and guide, Dr. Sharda Jain, firmly believes and wants to infuse every member of NIGF that I am the best. That means every colleague of mine in NIGF is best and will strive to prove that. I quote, good, better, best. Never let it rest till your good is better and your better is best. So before I go on for the academic session, on this auspicious day, let us invoke the blessings of Lord Ganesh and Ma Saraswati by lamp lightning. May I request dear Malti to help us in this auspicious ceremony. Malti, please. Till now, Malti is sharing the screen. Let's enjoy the bliss, this divine bliss, for 2 minutes.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Malti. Thank you so much. Now it's my proud pleasure and privilege to request and invite Dr. Sharda Jain, Secretary General DGF, for her opening remarks. Ma'am, please.
Great good afternoon, everybody. North India Gynecologist Forum is a reality now. धुंधलापन सब खत्म हो गया है. नई उषा आपके सामने, आशा, उत्साह और आत्मविश्वास की भावना का संचार जन जन में है. हर इस जर्नी का हिस्सा होना चाहता है. हर launch के दिन 20 minutes before people joining speaks very high about everything. Positive vibrations which were there on that particular day, one had to be present to see it, then only one can believe it. North India Gynecologist Forum के प्रेसिडेंट के रूप में डॉक्टर साधना गुप्ता एंड प्रेसिडेंट इलेक्ट के रूप में डॉक्टर रागिनी अग्रवाल, ये ऑलमोस्ट तय ही था. बड़ों की एक ऑफिशियल मोहर लग जाए, उनकी ब्लेसिंग्स मिल जाए तो काम बहुत आसान हो जाता है. So I think with these words, the platform is open to the working team now. Our blessings are with them, and I'm sure we will definitely interact and यूनिटी के लिए काम करेंगे, पर एकेडमिक एक्सीलेंस भी, वेयर इंफॉर्मेशन, नॉलेज एंड स्किल को शेयर करना बहुत इंपॉर्टेंट है. With these particular note, I will invite Dr. Ragini to say opening remarks.
Thank you so much, madam. Thank you so much. Very good afternoon to all of you, and thank you so much for joining this N.I.G.F. As madam has said about the academics, from me, the first step is the unity. This united front, we want more and more members. Today we are launching academics, but we should not forget, whoever have joined N.I.G.F, our one duty is to bring at least 20 members each, and by the end of the month, we should have 2,000 members in our fold. That only then this torch bearing will go forward. So I will not take much time, will forward to the next speaker towards our academic excellence. Over to you.
Thank you.
Thank
you so much. Thank you, Dr. Sharda Jain ma'am and Dr. Ragini Agarwal ma'am for your blessings. Now we start our academic activities. The first session is about a talk, and this talk will be delivered by none other than our President N.I.G.F, that is Dr. Sadhana Gupta. My heartiest congratulations to you, ma'am, and it is my proud pleasure and privilege to welcome you to deliver this talk on a very pertinent topic, that is adolescent PCOS, beware and be aware and update. And here, let me take this opportunity to introduce our experts for this session. We have Dr. Ashmita Rathore. She is the face of Delhi and she is the president of AOGD. We have Dr. Archana Verma, Vice President FOXI 2021. We have Dr. Meenakshi Ahuja. She is the Clinical Secretary, PAN-DGF, and now she is the Joint Secretary of N.I.G.F. Dr. Punita Mahajan, she is the President of DGF Outer Delhi branch. All of them are illustrious academicians. And now may I request Dr. Jyoti Malik to officially introduce Dr. Sadhana to this august audience and invite her for a talk. Over to you, Dr. Jyoti.
Thank you so much. Thank you, Dr. Jyoti. It is my proud privilege, actually, that I am the opening batsman for the opening president to introduce her. And it is my proud privilege to introduce our president of N.I.G.F, that is North India Gynecologist Forum. Madam has been a co-chair CEFOG NCD committee. She is vice president FOGC 2016. She has been the ICOG governing council member and has been the best ICOG awarded for it in 2021. Ma'am has been honored at various national and international forums, and she is the FOGC presidential candidate for election year 2023. So over to Dr. Sadhana ma'am for her talk, and for the experts, we would take their comments at the end of the talk. Thank you, and over to you, ma'am.
Thank you, Dr. Jyoti, for kind introduction, and my regards to Dr. Sharda Jain, and my loving regards to Dr. Ragini, who are the founder. And this is an auspicious day for us that we are starting our first North India Gynae Forum Academia series. So I am overwhelmed with the faith and belief by the North India Gynae Forum, our mentors, our teachers, our members, senior members, to bestow me this position of President of North India Gynae Forum. And we are going to work for unity, excellence, and instilling confidence in each and every member of North India across the 7 states. We still have to tap our untapped potential. We have to involve, we have to include, and we have to expand. So with this gratitude, I'm coming to my topic, that is adolescence and PCOS, because both are enigma. They are difficult to understand and difficult to define. And PCOS, where we are today, it is a common, complex, heterogeneous familial disorder It is affecting 5 to 15% females of reproductive age and seen across race, ethnicity, and the socio-economic background. Why it is important for adolescent? Because it has become an important reproductive health issue, which have a significant effect in the health-related quality of life. It is the most common and the frequent endocrinopathy. Everybody will know it, everybody sense it, and how it is characterized: chronic anovulation, hyperandrogenism, and the polycystic ovaries on ultrasound. What is important that it usually presents at puberty, and still we don't know actually what is the prevalence of PCOS in adolescent, but it can be ranging from 1.14 to 5%. And South Asian race is a little more prone to develop PCOS, like diabetes disorder and the thyroid autoimmunity. A lot of research and a lot of association and a lot of patients, still we don't know actually what causes PCOS. It is exaggerated LH response causing and hyperandrogenemia, then causing follicular arrest, or it is an insulin resistance which cause hyperandrogenemia and the oligoanovulation. So it is a vicious cycle. Insulin resistance can cause it, and the exaggerated LH response can cause it, and we don't know actually what is happening. It has the development in utero. So now we have this Becker's hypothesis that the fetal origin of adult disease, and it is a IUGR baby coming to childhood obesity, coming to premature puberty, and when we get the adolescent girl in our clinic, we think that this girl might be having PCOS because she is having hyperandrogenemia and the irregular cycles. But the things are not that easy. What we see, it is a classical presentation. What we see in the textbook, the patient is obese, she is having acne, hair growth, she is having the delayed cycle. But like adolescent, we have got the usually the confused, that is the complex and the mixed presentation, and especially this is important for the adolescent age group. So what is the present perspective for PCOS? That even our professional bodies have the different guidelines, and adolescent and PCOS combination make them more complex, and that's why we are over-diagnosing adolescent PCOS and we are missing adolescent PCOS. While adolescent, we have to be very, very careful because they are growing, they are in making process, and a lot of normal physiological like immature hypothalamic pituitary axis, a little acne, and ultrasound we are doing abdominally. So there are a lot of issues, and my first message to all the audiences that when we see or the patient comes to you that I have had the PCOS, be careful to diagnose it. What is the complexity of the PCOS diagnosis? Because it is a heterogeneous disorder. It is a genetic. Patient can go to dermatologist, she can go to the physician, she can go to us because of oligoanovulation, and she can go to some cosmetologist because she is having hirsutism. Likewise, like PCOS, adolescence is also a confusion picture because many things are common. Acne are common, weight gain is common, thyroid and prolactin disorder, a lot of psychological stress, especially for the Indian adolescent, and suboptimal imaging, and that makes that we should be very, very careful that we don't do incorrect diagnosis and we follow some rules, and we have to be updated with the many new upcoming thing. What is the recommendation? Now, why we want to diagnose PCOS at the adolescent when she is not going for marriage or the childbearing? Because PCOS have got the long-term implication, chronic anovulation, then infertility, then metabolic disorder in reproductive and elderly age, and the risk factor for cardiovascular disease and the cancers of endometrium hyperplasia. Now, South Asia is rightly struggling with tsunami of NCD, and it is very important that we rightly diagnose at right time adolescent PCOS. And again, over-diagnosis to under-diagnosis, we have to be very careful. Now I come to what are the complexity of defining and diagnosis. We have to pick up right because we have to do the certain test and we have to wait some time for adolescent that this girl is having PCOS. And this is very important slide that when we have got the certain many criteria, N.I.G.F, Rotterdam Androgen Access Society, it is important that we have a broader base for diagnosis, like the Sultan Paris criteria say at least 4 out of these 5 criteria, that is oligoannulation, signs of hyperandrogenism, biochemical as well as clinical, insulin resistance, and polycystic ovaries. We must have at least 4 out of 5 criteria, and don't diagnose PCOS only on 1 or 2 criteria. Likewise, Rotterdam criteria, all the 3 criteria should be present when we define that this girl is having PCOS. And this is very, very important. Not only 1 or 2 findings or 1 or 2 symptoms. Don't say that this girl is having adolescent PCOS. And why it is important? Because it is a growing age. It is a mature hypothalamo-pituitary axis, and we have to know actually what is oligoannulation. Now, we have the 2 spectrum. Few people say every girl 14, 15 years. Yes, it is common to have the delayed cycle. One thing that only on the first visit we say that, oh, you are having PCOS. So we should be very, very clear what we say. When we have the less than 20 or 90 day cycle, it is considered abnormal and require further investigation. And we have to look for the clinical sign of hyperandrogenism. So when we say it is oligoannulation, when the menstrual interval is more than 90 days, even after 1 year, and if the oligoannulation persists after 2 to 3 years of the menarche. So wait for the thing that how the patient is settling, how her menstrual cycle is resuming, and don't make the instant diagnosis. Hyperinsulinemia, yes, we say that the hyperinsulinemia is like the basic positive factor for PCOS, but both insulin resistance and hyperinsulinemia are common in adolescent, but they are more severe in the adolescent PCOS. So we should have a close watch for it, that it is when it is crossing abnormal to normal. And at this moment, the family history, it is not the gut. Always ask whether your parents have got the hypertension or diabetes, or they are also obese or the high weight gain. And these girls are to be followed for the polycystic ovarian syndrome. Now, hyperandrogenism is a very, very crucial thing, because sometimes we really order a very, very costly investigation for a girl who is like very middle or low socioeconomic condition. And we have to say that when we need to have the androgen profile. So clinical hyperandrogenism, that is the severe inflammatory acne or hirsutis, are considered surrogate marker of hyperandrogenism, and we take it as a marker of hyperandrogenism. And sometimes we have to do the testosterone panel. The problem with the testosterone panel is that they have the pulsatile diurnal cyclical change. A single value does not give you the real result, and the lab the quality of the lab, what quality of test they are doing. So this is very, very important, that this should be the reliable reference laboratory validated test. Only then we can have certain criteria and certain diagnosis for hyperandrogenism, and the total and free testosterone marker are considered good. And when we do for suspect the adrenal source of hyperandrogenism, then the adenosterone and the DHA is to be done. So these are the recent recommendation in pediatric, and I've taken pediatric because Gynae, Pediatric and Hyperandrogenism Society like see the adolescent girl from the different level. So it is important. One again, second message, when the patient or the girl is having any topical or the systematic therapy for the acne, it is good that we already exclude, or we before starting treatment we exclude, or we have certain tests that this girl is not having the PCOS also. So this is important. And when the patient girl is having comedonal acne, it is fine, but the severe inflammatory acne, then we should be careful that this girl can have the PCOS. So this is very important, that the surrogate marker and looking at the patient is very, very important. PCOS is not the first diagnosis. This is very important in the current scenario when we label every third or fourth girl as PCOS. First, we have to exclude, and the especially important tests are the thyroid disorder, prolactin disorder, and when you suspect that the classical adrenal hyperplasia. Now, the another important issue is the what is the PCOS morphology, because every girl comes, it is the experience of clinician all over the country that the patient comes with ultrasound report that I have got cyst in ovary, and it is important that adolescent girl, their ovaries are in making, multifollicular pattern is common, and we are doing usually abdominal ultrasound, and now the criteria is that the ovarian volume should be 12, the follicle should be more than 20, but this ultrasound should be done around 8 years post-menarche. So in the initial years, in the initial 2 or 3 years, the ultrasound is not recommended for diagnosis of polycystic ovaries. This is very, very important message I want to give, because this is unnecessarily causing anxiety and mental stress. So we have to think clear and talk simple. What is oligoanovulation? After 2 to 3 years, if it delayed cycles are persisting, what is clinical and the biochemical hyperandrogenesis? Pelvic ultrasound not recommended for diagnosis for PCOS 8 years post-menarche. AMH level not recommended for PCOS diagnosis in adolescent because we don't know the normal value, and exclude other disorders. So these are the important things. Now I wish to share one or two very, very important concepts in PCOS, and these are not theoretical. Actually, they are affecting our management. And when we are shifting from insulin resistance and obesity to what is etiopathogenesis, that is genetics, epigenetics, gut microbiome, and the molecular toxicology, that is the environmental toxin. So genetics and environment, actually it is what some makes what we are, what we are, it is this. So even the girl is genetically susceptible to PCOS, but if she is having healthy lifestyle, then the PCOS manifestation will not be there. So this is very important. And a second important change in our perspective is that it is not the adolescent age where the PCOS manifests. When there is a prepubertal obesity in girl, or prepubertal obesity even in boys, that is the time that we should think of the family history, what is the going on in family, and this is the time even before adolescent, the lifestyle and the still like all the lifestyle measure really work, and we can really intervene in the right time. Now coming to, I will go with this quickly to how to clinical approach. The important thing is we have to select that this girl should be screened further. How we demonstrate androgen excess, how we exclude other diagnosis, and how we ascertain the hyperandrogenemia. So we have to see the patient. William Osler have said everything about what the medicine should have, and it is still gold thing for each of us. So family history, personal history, how girl is looking, and how she is having menstrual calendar, and it should be in the diary. And if she is taking treatment for any cosmetic like acne or the hirsutism. What is secondary sexual character? As the patient is having acanthosis, because many times patients herself says, I have these striae in the abdomen and I have this thing. So we have to have a good look to the patient overall. Exclude everything what we have says, thyroid, prolactin, adrenal source, pregnancy test. Whenever you think, I think it is one of the important thing, and we have to exclude the diagnosis with a good lab test. But I again emphasize what is not recommended for adolescent PCOS diagnosis, that is PCOM, insulin resistance, the biomarkers, AMH, they are not recommended for the diagnosis. So once PCOS is confirmed, we have to think that this girl is having any like susceptibility to metabolic disorder. It is not required for every girl, but if we want to do fasting, insulin level is not recommended, but fasting and 2-hour postprandial blood sugar level are recommended, and lipid panel only in obese and overweight adolescent PCOS, because it is the adolescent group. And these are the criteria when we think that this girl can convert into the metabolic disorder in reproductive and elderly life. And we should have these criteria. What is the blood glucose level, lipoprotein, and other things. Coming to final way, we want to manage, we want to make everybody healthy and fit, and the adolescent PCOS management is a big issue. Why we want what the patient's concerned. She is concerned of menstrual irregularity, hirsutism. She is concerned for her examination. She is concerned for her relationship. We have to be little focused on it, what the girl and family want, and the lifestyle modification is the thing. which is going on first, second, third. It is going to from pre-pubertal to the like the later age, and we have few pharmacological agents to deal with it. So lifestyle intervention, we talk a lot about a good diet and good exercise, and we in reality we do the opposite. Whatever industry, whatever technology, whatever way of education, actually environmental is not feasible, not like a positive for the health practices, and we have to really work hard that how we can do the good lifestyle modification. Now, this is dogma theory. What we say, it is Indian philosophy. What we say what we are, what we eat, and the dysbiosis of gut microbiome. This is a dogma theory which is very, very important, which says when we have a high sugar level or like a poor diet, then it results into the disturbed microorganisms, disturbed microbiome, and there is a lipopolysaccharide, there is a inflammatory stress, and this can cause PCOS. And it is a real point of thought, because in last 15 years, the way our diet has really changed in India, and we have seen the surge of PCOS in our adolescent population. This is the way, and this has changed our lifestyle management, because now we are not focusing on quantity, not only calorie restriction, we are focusing on quality of diet. So we have to say to adolescent what you should eat. So it is a nuts, it is fresh fruit, it is vegetables, it is the complex carbohydrate, and the simple carbohydrate and fat should be very low. Smoking is now like quite prevalent, tobacco, so we have to ask of it. Timing of meal is very, very important, because people are taking dinner at the right like 12 p.m., 12 a.m. or the 1 a.m. and protein consumption preferred at a breakfast. So now we are coming to a point when we say really what we are, what we eat, and we have to have inculcate the good dietary habit. We have to teach, while we are N.I.G.F is taking a start. We have to go to schools like we are doing it, but we have to enforce it. What is good diet? What is bad diet? Because the hydrogenated oil and packaged food, which are abundant in today's market and being sold by celebrities, our work for going for the good lifestyle and a good food and exercise is really very, very tough, because all celebrities are selling all these junk food. Now coming to COC, as a August obstetrician gynecologist, we know what COC. Why COC is important? Because they correct endocrinopathy and they correct dermatological manifestation of PCOS, and evidently they correct menstrual irregularity. So COC becomes the first line of choice whenever the patient wants to have having delayed oligoannulation along with the lifestyle modification. How to choose COC? So when the girl is obese, weight gain, then the drospirenone one. If the girl is having acne and hirsutism, then the cyproterone. But there is a little issue about some embolic, but we don't know. The Indian studies doesn't confirm it, and we can go to the cheaper one because it has to be done for the 3 to 6 months. Now, again, a word of caution about COC. Yes, COC correct endocrinopathy, COC corrects symptoms also, but how long COC in adolescent? This is important, because actually we don't know what is the long-term consequence on fertility, what is the possibility of cessation of growth in perimenarche, likelihood of post-film amenorrhea, and the girl is having migraine, what to do about it. So it is important that what is the WHO criteria for prescribing COC, we have to take consideration when we are prescribing for the adolescent PCOS. Progestin only in luteal phase do the withdrawal bleeding, and I want to emphasize that it doesn't correct the endocrinopathy. And it is good that when we have done 3 months and we want to see the lifestyle and other things are working, and see that the patient girl is resuming their menstrual cycle, resuming a little bit the feature of hyperandrogenemia, allow the body to work. And if it is again 6 or 7 week overdue, then we can go for the progestin withdrawal bleeding. A word about insulin lowering therapy. Metformin is the first drug which we have a lot of experience, because it corrects insulin resistance. It has the help in the menstrual cyclicity and ovulation, but a lot of side effect. And in the adolescent girl, actually there is an issue, and it is to be recommended lifestyle, sometimes short COC. And when especially she is not able to reduce weight or she is not responding, we can add metformin. Inositols have come in a big way as the secondary insulin messenger. And inositol, what is beauty of inositol, that they are nutritional product. Anyway, they are present in our food, that is fruit and beans. So what we are recommended for the lifestyle modification, we are giving in the form of pills, and MI and DCI ratio, in the ratio of 40:1 is said to say that it reduces insulin resistance and correct the endocrinopathy. So inositol are the thing which is friendly. It is costly also, 3 to 6 months. So it is not a pharmacology, it is not a hormonal drug. So it is important. N.I.G.F, probiotic and prebiotic, these are all being tried. A lot of research is being done because the resolution of 2020 says that we should treat the disease by the drug. Anti-androgen, usually as a OB/GYN, we don't prescribe. It is a spironolactone, flutamide, finasteride, but it is important that these drugs can be the liver toxic, and it is usually not in our domain, and it is better when the girl is having a lot of problem, we refer it to the endocrinologist. So combination therapy is there, lifestyle arranged with the COC and insulin sensitizer. Inositol has the role, and so wise the certain other anti-inflammatory drugs also, what we say, that reduce the antioxidant drug, and anti-androgen only with the multi-speciality with the advice. It is important that COC can be given as contraception in sexually active adolescent, and when we are giving only metformin, that if reduce insulin resistant and the girl can become pregnant. So a word of caution. Mental health has come in a big way after COVID. With these girls, there is relationship issue, there is appearance issue, there is a fear of infertility, and sometimes OB/GYN also threatened that you will have diabetes, you will don't have children, and the mother, father. So a lot of issue. We doctor, be careful that don't add to her emotional agony. You don't eat, you are not doing well, you have not reduced weight, you are. So it is very, very important that we should be compassionate. We should say, you should eat this thing, and you can have this variety, and it's fine, it is okay, you can do this thing. So we have to have a good support, and we have to develop that communication skill, and we have to have some cosmetic like backup therapy so they can come to it. So in India or in all over the world, we try everything, acupressure, acupuncture, massage, but still no studies have proved its efficacy. A lot of research we can do with N.I.G.F. We can think of, we have a prime institution in North, 4 or 5 aims, Chandigarh, PGI Chandigarh, SGPGI. And it is the time that we really tap these academic excellence centers and their teachers for these studies for which world is waiting. We don't have the longitudinal study during adolescent PCOS, good diagnostic criteria for identifying PCOS, what is the normal value for AMH, FSH, LH, and how we can clear the thing that what drug is being effective. So it is time, as a North India Gynae Forum president, and with our mentors, Dr. Sharda, Dr. Ragni, all of this, we are VP, Dr. Asmita, all, what is the prime? We are having the peak research institution, and it is that real time that we come forward for doing many research, and many of the private practitioners who are research minded can join these studies because world is looking for these research studies. So to sum up, we have to have correct diagnostic criteria. We have to wait for diagnosis the PCOS. We should not overdiagnosis, neither miss the diagnosis of PCOS, and always individualize the treatment. Be careful. Thank you once again. It is North India, from Himalaya, from so it is the time that we really recognize our beauty. What we madam says, love yourself, appreciate yourself, and like yourself. And it is that time when we recognize our North as a source of beauty, religion, philosophy, science, research, and compassionate medicine. Thank you very much once again for making me president and instilling faith in me for that post. Thank you very much.
Thank you so much, ma'am. Thank you for such an enriching talk and making the thing so clear that as a clinician, There's no doubt that we should be aware and at the same time beware of adolescent PCOS so as to prevent complications later in life. And the best part is we should think clear and talk simple. Now, may I have our experts, please? We would love to hear from Dr. Ashmita Rathore. Ma'am, are you
Yeah,
there?
thank you so much. Am I audible?
Yes, yes, very much.
Yeah. I think at the outset, I would like to express my great satisfaction and that I am part of this historic movement and this event of the first academic activity of N.I.G.F. And I have an opportunity to be part of this movement as a part of a President AOGD representing them. And congratulations, Dr. Sadhna, for becoming president of this particular program and for your excellent presentation. And very nicely emphasizing that adolescent PCOS is increasing in incidence. And at the same time, we really need to be careful that since there is a great overlap between the physiological changes in adolescence with the diagnosis of PCOS, we should be very, very careful in making the diagnosis and avoid overdiagnosis. At the same time, correct diagnosis and correct therapy is very, very important. She has very nicely emphasized on how the treatment of PCOS in adolescents is different than reproductive age women. And I think it was a great update for all of us. Thank you so much for your presentation. Thank you so much.
Thank you so much, ma'am. Thank you for your expert comments.
Please, everybody mute themselves. Please mute yourself.
May I now invite Dr. Archana Verma for her expert comments.
I am audible. I am audible.
Audible, ma'am, but it's breaking.
Yes,
the voice
yes.
is breaking.
Voice is breaking. Okay. So now.
So I think the whole webinar, I think there's a problem. Everyone's voice is breaking.
Archana ma'am, your voice is cracking.
I think problem today I should not speak much.
Ma'am, you can understand you. Please continue.
Let someone else.
बढ़िया सुनाई दे रहा है, बढ़िया सुनाई दे रहा है.
Dr. Archana, you can continue. We can all hear.
Meenakshi, over to you.
I just want to say that, of course, everyone has congratulated Dr. Sadhna for being the president of the N.I.G.F, but more importantly, she's the opening batsman of the new academic series that we have. So a big congratulations. I think no one better than her to start this series. Wonderful talk you've had, clearly explaining the role of ultrasound and biochemical tests for PCOS. They are in adolescents, which are very different from what we do in adult PCOS. And I was very, very happy that you highlighted on the mental health, because we all have to learn to be empathetic. These children are having, these youngsters, I would like to call them young adults or adults to be, and they have to be treated like that. We can't talk to them like they're children, even if they may be 16-year-olds. We have to be very empathetic, try to explain to them, instill confidence in them, because compliance comes, whether it's with exercise, diet, or medication. The compliance comes only when the patient trusts you, because 90% you will see that the mother and daughter are anyway fighting in front of you. The mother will say, ye khati hai, kehna nahi manti, ye wo, the girl will stare at the mother. So the very important thing is that she has to have, as a youngster, confidence in the gynecologist so that she follows the treatment, be it non-pharmacological or pharmacological, and comes for continuous follow-up so that we can get good results. Thank you, Dr. Sadhna, once again, for the wonderful talk that you did.
Thank you. Yeah, now I will say a few words also. So first of all, good evening, everybody. And first, most thing before I comment on Dr. Sadhana's talk. And I must say 3 things we must remember. And before I say congratulations, and big congratulations to a big N.I.G.F. And this is going to rise and shine like a super shining sun with full energy and full light. We have learned the habit of cooperation. We have to learn the feeling of integration and commitment, of course. With these 3 things, we can meet and we can do the work like anything, because Sharda Jan madam, as I know, as I remember, as I feel, is something beyond my imagination. Once in a lifetime, you get one opportunity to meet your actual spiritual guru, and that opportunity when you get, you have to just fix it up, and then the things go and fall to its maximum. And this is then now I think I must talk about one शायरी which I am very fond of saying, that ना हम लोग हम कभी किसी भी चीज से किसी दूसरे से अगर कंपैरिजन नहीं करेंगे, then we will be much better ahead. सबका मकसद अलग है जिंदगी में, सबकी मंजिल अलग है, ना आप किसी से होड़ कीजिए, ना किसी के साथ बैर कीजिए, अपनी ही मंजिल अपनी ही दौड़, then one will be successful. And the second thing is this adolescent PCOS is, we must take it as a pandemic. It's a silent pandemic. That diagnosis is so much delayed that when the patient comes, all the adolescents, they are very fond of their figure, their features, and this is the thing, this silent thief. This PCOS is a silent thief to their beauty, and this hirsutism, obesity, acne, hair fall, whatever they can think about beauties, this is taking away. And then we have that male hormone developing, and this is a time of a female enhancement and female empowerment. So we must look for this male hormones taking charge of our body. We should avoid it. And then secondly is metabolic disorders. We should take it. So this diagnosis, if we are done, then we have to tell them, because the treatment as such is again something very simple. Not too many things are needed to diagnose it, because everything is in clinicians' hand. They have to talk to them and they have to counsel them, and then with clinical senses only you can diagnose. Thank you very much. And I think the faculty is too good. Dr. Sadhana is amazing, and her talk was beyond imagination, very well documented, very nice. And this all the best to Norzone. And I must say, what else I can say? Good wishes to each and everybody. Now next faculties, Dr. Punita madam and Dr. Meenakshi, as usual, too good. Dr. Asmita madam, and my namaste to all. Thank you very much.
Thank you, Dr. Archana. Thank you very much.
Thank you, Jyoti ji.
Yeah, good afternoon,
Ma'am, you're
everyone.
muted.
Yeah, let me,
Oh, sorry.
yeah, let me first congratulate Dr. Sadhana Gupta for taking the leadership role. And ma'am, also congratulations for choosing the first academic topic as adolescent PCOS, which is still an enigma. And as you very rightly highlighted in your talk, beautifully explained how the diagnosis is very difficult, because changes of puberty, they overlap so much that many times it is overdiagnosed, and at times, of course, underdiagnosis is there. And I think you've very highlighted the role of lifestyle modification, mental health, and we have to be very careful in treating these young girls. I think your talk was excellent in covering the role of COCs and the role of metformin and the role of giving anti-androgens. And I think it's beautifully covered. And I wish good luck to our forum, which will grow under the aegis of Madam Sharda Jain. And I'm sure we all come up to the flying colors. Thank you very much, Madam.
Thank you. My sincere thanks to Dr. Sadhana Gupta and all the experts for taking out their valuable time and giving their expert opinion. Now we move on to our second session, and I would invite Dr. Jyoti Malik to please carry on this, conduct the second session, invite the moderator, co-moderators, and the panelists. Thank you very much.
Thank you so much. Thank you. And when a collection of brilliant minds, hearts, and talents come together, we expect a masterpiece. And here we have our panelists, the masterpiece that the NIGF, actually the masterpiece that has been created, and now that we'll keep on seeing further more such sort of masterpieces in our forthcoming uh, webinars. So we have this panel here, a panel discussion on the reproductive and sexual health, the key challenges and solution for India adolescents. So for this, we have moderator, Dr. Kiran Pandey ma'am, and co-moderator, Dr. Pavika Lal. So we have Dr. Kiran Pandey ma'am, who's the ex-HOD, and she is Professor, Department of Obs and Gynae, GSVM Kanpur, and she is ICOG Governing Council member 2021-22. Then the co-moderator, Dr. Pavika Lal, is an assistant professor at GSVM Medical College, Kanpur, and I think we can quickly go through her CV. We can read it through because we would be saving time if I have to read it out. So coming on now to our experts, we have Dr. Ragini Agarwal. We have heard her. We all know her. We have all seen her working. And she is the vice president of N.I.G.F, and she is president-elect of N.I.G.F. Other than the whatever we can read on the screen, she has been the vice president of FOGSI 2020. And then we have Dr. Amritpal Kaur, who is the professor, head of department, Government Medical College, Amritsar, and who's also president of AOGS. Then we have Dr. Meenu Vaish, who is Director Consultant at Meher Hospital, Dehradun, and she is also the President of Uttarakhand Chapra Obs and Gynae chapter. Then we have Dr. Mala Srivastav. Dr. Mala is also the Secretary General of N.I.G.F. So many congratulations actually to each and everyone in N.I.G.F who has contributed and who has come and who would be coming. So my sincere thanks to each one, and God bless us actually. So that is the only line I can just say now. Dr. Professor Mala Srivastav is a senior consultant and professor of GRIPMA, Sir Gangaram Hospital. She has been past president AOGD in 2021. Then we have Dr. Neeta Gupta, who is associate professor, Department of Obs and Gynae, Acharya Shri Chandra Hospital Medical College, Jammu, and she has been a teacher for the last 16 years with special interest in high-risk pregnancy. And the finalist, the last but not the least, we have our own Dr. Anita Rajoria. We can read through this busy slide, and she is actually a chairperson of the Adolescent Committee of AOGD, and I think it would be better if we all listen to her, and I give over to our moderators, Dr. Kiran ma'am and Dr. Pavika ma'am. So I would be sharing and giving it over to you, ma'am, for the panel discussion.
Thank you so much for nice Dr. Jyoti.
Yes.
Am I audible, Dr. Jyoti?
Yes, ma'am. Yes, Dr. Pavika. You're clear.
No, I'm Dr. Kiran Pandey.
Yeah, Dr.
Am
Kiran,
I audible?
Audible. Yes, ma'am.
Okay. So thank you, everybody. And really, it's extreme pleasure to be part of this first academia series. My great regards to Dr. Sharda Jain, who she has mentored this N.I.G.F like anything like her baby. And our president, Dr. Sadhana Gupta, who has given me this opportunity to be part of this first academia series. And I cannot stop saying one word. It was an excellent lecture which she has given on adolescent PCOS, beautifully covered not only the things which to be done, not to be done was also very, very important. So I love that. And I think everybody has been benefited on that. Now, let's start with the panel discussion without wasting any moment. And as you all know, it is on the reproductive and sexual health, basically, which is the most important in present day time, key challenges and the solutions for the adolescent. So, is my, sorry.
Ma'am, I'm moving the slides.
Ma'am, the slide is not moving. It is only the first slide, panel discussion dikh raha hai.
Ma'am, I'm moving the slides. Hello?
Yeah,
am I audible?
Yes. Yes, we can now see Kiran Pandey ma'am's, yeah, it's moving now. We are on to introduction.
Slide sharing, I am doing my slide sharing. I'm doing, Kiran Pandey ma'am is just talking. I'm doing the slide sharing. So it's the slides moving?
Yeah, they
Yes,
are.
ma'am. Yes, ma'am, it is moving. Right now we are seeing
Ma'am,
introduction.
please go ahead. Okay, ma'am, please go ahead. Ma'am, you're muted. Kiran ma'am.
Okay. Pavika, there might be a few seconds time lag because I am in US. So that just wait for a few seconds if ever the situation comes like that. So first, I will welcome all my panelists, and in fact, very rightly said by Dr. Jyoti that they are all experts of their fields. So it is again a very important that way a landmark panel discussion. So as you all know, already told you, nearly 35% of the global burden of the disease basically has roots in adolescence, as pointed out by Dr. Sadhna also. We all know that Baker's hypothesis. And that is the reason that we have to focus on here. We all know the age group. We all know what changes do happen in this period, not only physical, cognitive, psychological, everything. They are making the largest proposition. India being the young country, the country's 21% population of the world, it shares 21% of the world population. And we all know the specific problems, which there are very important things. Today, what we are going to discuss is which actually require awareness because they are less discussed. So that is early recognition to avoid the other complications, specifically the sexually transmitted disease and the teenage pregnancy. And their menstrual pain disorders and menstrual bleeding disorders, about which we all know, and we know the importance presently now. I think in last few years, a lot has been talked about the menstrual hygiene also, which is important. So now let's come to Dr. Ragini. Are you there? So I would like, so I would like to know from you only, you are the opening batsman, not only of N.I.G.F, but also of our panel also. So let's see, what does MHM stands for and what are its components?
Thank you so much, Dr. Kiran, for asking me this question, because the women intimate health is something about that I'm so passionate. Corona time, I have had a whole webinar series on this. We all know that the menstruation is a point, first menstruation when a girl turned into the womanhood. So it is a natural, normal, biological process experienced by all adolescent girls and women, but we don't spoke about it, causing unnecessary embarrassment and shame. Almost 113 million adolescent girls are vulnerable at the onset of menarche. They need a safe environment and offer the protection and guidance to ensure basic health, well-being, and educational opportunity that should be realized. But if there's no toilet, no facility, so it's a position when they don't feel dignified. So it is basically, when we talk about the safe and effective menstrual hygiene management, that is what MHM stands for. is a trigger for better and stronger development for adolescent girls and women. As
Very
far as
nicely explained, Dr. Ragini.
yeah, so when we talk about this, just a 2 line more, Dr. Kiran, that we should know that it is the integral part of the Swachh Bharat Mission guidelines, and it is issued by the Ministry of Drinking Water and Sanitation to support all adolescent girls and women, and it outlines what needs to be done by the state government, district administration, engineers, and technical experts in line departments and school head teachers and the teachers. Over to you.
Yes, so nicely not only explained but given the guideline also. And so to summarize, we can say one has to have access to the knowledge and information, access to safe menstrual the absorbance, water sanitation, as you said, the technical persons and the state government has to ensure that, and of course, access to safe disposal. So over to you, Dr. Pavika. You can take the next question.
Okay, ma'am. Thank you so much, ma'am. Sabhi ko mera pranam. So coming on to sexually transmitted infections, we all know that each year an almost an estimated 374 million new infections occur worldwide with infections. So what is the most common cause of STI in adolescents? The question goes to Dr. Amrita Pal Kaur, ma'am.
Thank
Is
you
ma'am there?
for making me part of this program. I would like to say the most common bacterial STI in today's world is the chlamydia infection in the adolescents. And the second most common is the gonorrhea, and followed, though they are of different type, bacterial, fungal, or parasitic. And the girls, they do get the human papillomavirus infection at this time also. But the biggest problem with this is they are, most of the cases, they are asymptomatic. And the symptomatic are only the tip of the iceberg. So we have to target the asymptomatic by screening and treating. And if we do not treat at the asymptomatic period, this has got lifelong reproductive, long-term complications with PID, with infertility, with chronic pain. So HIV, syphilis, there are other STIs, but the most common is the chlamydia with gonorrhea. Mostly chlamydia and the gonorrhea, they occur together.
Yes, ma'am, very correctly said. Over to you, ma'am.
Yes. Yeah. So basically, very rightly explained about the bacterial. So is Dr. Meenuvish is there? Because I think she is having she has become COVID positive.
So
is she here?
Cover this, ma'am.
Okay, so that anybody one by one can cover this. So what are the basically guidelines say about this ACOG and the CDC guidelines? What do they say about their
CDC recommends that all the sexually active women of less than 25 years, they should be screened every year. And for women more than 25 years, only the high risk women that having the multiple sexual partners, more than one partners, or out of marriage relationships, and those should be screened annually. And for men, if the men are having men having sex with men, they should be screened. Otherwise, the annual screening of the asymptomatic men is not recommended. And how you screen is by history taking and of vaginal discharge or perineal discharge or penile discharge with urinary problems of burning exudation, frequency of exudation, or even rectal discharge, rectal pain. These are the symptoms if they have the anal sex or oral sore throat and cough, so oral sex. So we have to go by the history and then take the swab from the vaginal swab or even from the urine. This can be tested at the point of care, also on site, where whenever the patient comes, give it a test. Right? NAT is the most commonly recommended test, but if it is not available, we have to go by the like syndromic approach, as we commonly don't have this test.
We'll discuss about that. Madam, I know you are very your experiences of the whole life is so much that
Can I
even
add
without
something,
NAT,
Kiran ma'am? Can I add
yeah,
something, ma'am?
yes, you can add, Anita, but let's all be limited and
Yeah,
because we have to
only
finish
one
in
line
time
to add, because we have to give focused attention to the victims of sexual assault, those survivors who are coming. Because even if there is an indirect evidence, like they have genital warts, or there is any other evidence, we must screen these young children and adolescents for these infections. That is the only thing I wanted to add. And when we are collecting samples for their medical legal examination, it is our utmost responsibility as care provider to screen for these infections and give them prophylaxis for these if it is already.
Yeah, so this comes into even the guideline when these sexually assaulted children do come. How do you have to take various swabs and all that. I mean, at the moment we are not going into it, but very nicely pointed out that this part has to be focused, Dr. Anita, very right. So let's start with the case discussion. And there comes this is a girl of 19-year-old, and she had a history of a recent irregular bleeding. She is with her current sexual partner for 4 months and who has recently stopped using the condoms. We have taken this case very simple one and the clear cut. So without going anywhere else, we'll be focusing on our topic only basically. So after taking her consent, because she was sexually active, it was found on examination that vulva, vagina, everything was healthy. There was no inflammation. Small cervical ectropion was there and profuse mucoparallel discharge. No tenderness on bimanual examination was there. So Dr. Mala Srivastav, let's start with you. How will you approach?
Now, this patient, she has a history of irregular bleeding, and she recently she has been on regular sexual relationship. Now we have to take history whether she has taken any IPIL or emergency contraception, because she was not using any condom recently. So whether from the history we have to take whether she has been using any emergency contraceptive. That history is important, and that can give rise to irregular bleeding. And secondly, we have to also see on examination, you have said she has mucopurulent discharge. We have to take the discharge for examination, culture, bacterial vaginosis, chlamydia infection, all sorts of infection that we can take and we can test. We should do that. And then we have to give the syndromic approach, and we have to treat this girl.
Dr. Mara will come to that syndromic approach. At the moment, it's best to that like this patient is very often, I mean, they are asymptomatic also most of the time. So as you were very rightly pointed out, each and every point which was told to us in MBBS periods, the detailed history, and very nicely pointed out about the emergency pill, because these days they are available on the over the counter and anybody can take it. So one more thing, would you like to, supposing in certain cases you can't take they don't give clear-cut history, and can you take a swab from somewhere else also besides
Yeah, we can take endocervical swab, and we can also take rectal swab.
Yeah,
without any penetration. Yes, because we have to. Most of these girls, they may be asymptomatic, and we have to catch these girls, because even if they are asymptomatic, they may be suffering from gonorrhea and chlamydia, which can have long-term effect on their health. So that is important. We have to catch these girls, treat them, diagnosis that has to be done, and treat them also. Besides, we should also try to catch their partners, because their partners may also be asymptomatic. And it's important because they are in a regular relationship. So even the girl may be asymptomatic, the girl may be not be having any problem. If the partner is having problem, the partner needs to be treated. And because the partner may reinfect this girl again.
Yeah, very rightly pointed out. This point again, this can come only from the experts, that one should not ever miss the partner point. And you also have to be, she's a monogamous, or she's having multiple partner. And I mean, this has to be, can come out with a lot of confidence has to be established between the girl and the treating person. Only then she will be able to come out with these details. So that's excellent with it. Dr.
There is one more aspect, ma'am. Yes.
Can I add, Dr. Kiran?
Yeah.
These girls have to be told that even if you're treated, diagnosed and treated for STI, they need to be retested after 3 months. And their
Test of cure.
Should be retested for after 3 months, because these infections can recur again and again. So
absolutely.
Kiran ma'am, there is one more aspect. It is important to take history of partner. But like you said, she may be having contact with only one adolescent or one boy, but that boy may be having multiple partners. So it is, as Mala has highlighted, it is very important to screen the partner, and partner has to be screened for her. Means his partners also would need to be, if the confidence is there, you develop the rapport with the partner, then he should be also screened how many partners he has. So all this cascade screening has to be performed.
Yeah, so such important points have come out. And I mean, really, as I said before, then for this, you have to really establish a great rapport with that person. Only then everything can come out. Otherwise, they will feel they will not come out, and we will miss the things. And rechecking, because evaluation is again very important points. So Dr. Pavika, you can continue about the management.
Yes, ma'am. This question goes to Meeta Gupta, ma'am. What are the management strategies for ST in adolescents?
Thank you, Dr. Pavika. And at the onset, I would definitely like to first thank Dr. Sadhana ma'am and Shada Jan ma'am for giving us this opportunity to be part of this panel. The entire new organization, the North Society that we have, has been inaugurated today. So coming to my question, I think so the first and foremost would be awareness and, sex education that we have to give. Before anything, if any girl is coming to us with vaginal discharge, they have to be counseled regarding the use of barrier contraception, that, okay, because times are changing, sexual activity has become very rampant, and these kids are all trying to experience new things. But what they have to be made aware is about this use of barrier method. We cannot ask them not to go for any sexual activity, but what we can counsel them is proper sexual activity with use of barrier method. That is, I think so, the first and foremost thing as caregivers or health providers we have to supposed to take care of.
Sorry to interrupt, Dr. Meeta. I think the first thing should be their management and uptreat. Once we have developed that confidence and the problem is solved, then further we can take up these things in our...
Ma'am, I would just like to differ, because once we give them treatment, they will never come back to us. So you have to give us a little 5 minutes extra to counsel them for barrier method. Yes, treatment definitely, because that is the primary reason they have come to us. So definitely what ma'am is
thinking. It should be side by side. It should be side by side.
Okay. Yeah. Ma'am, yes. I don't know about these. For an adolescent, I would not be going much of tests and all, but a random blood sugar, that definitely I would advise them. A routine hemoglobin, and then both the partners screening and treatment of both the partners have to be taken care of, ma'am.
Yes. And what do you think? What should be the approach, as probably Dr. Pavika wanted to know?
Ma'am, I think so syndromic approach, everybody knows that, yes, we have to, everybody has to have that healthcare provider has to be taken care, giving a syndromic approach where we are treating the entire spectrum of sexually transmitted disease at one stop in a single go to our patients.
Yeah, the syndromic approach is one of the most important approaches. And as you rightly pointed out, investigations don't have to be, we don't have to focus too many. We can definitely go for syndromic approach, which is but the only thing here is just wanted to, I think Dr. Nita and all the experts will agree about it, that presently there is a changing WHO recommendation also. They have now the advisory body. They have not yet, I mean, I don't know, we have not yet started implementing advisory board group meeting reviewers and updates on STI treatment have recommended in the lights of recent developments. Like if you remember, initially there was the 1991, there was a management of STIs with the contest of HIV and STI control and prevention. 2001 and 2004, they came with the new guidelines under which we are presently doing all those syndromic approach, where there are different kits, gray kit, yellow kit, red kit, black kit. I mean, like that we know everything. But now in 2016, they have come out again, updated their concern, their strategy, because they want to end the STI by 2030. And the new guidelines, they do say the approach to individual infections, moving away from syndromic approach. Although I 100% agree with you, presently we all are doing with the syndromic approach because our limitations in the developing countries, where the facility, we ask them for investigation, then it will become difficult. But of course, we can think there are certain persons who are who have the approach availability and who can want to go for investigation. There we can take that individual approach also. I think Dr. Anita being the president.
Yes, ma'am. I'm very happy that you highlighted regarding screening for HIV. If I may widen the horizon, it is prudent and logical to screen these patients for other sexually transmitted viral infections like hepatitis B surface antigen or SCV, which can be, another component. Of course, this is beyond the scope of current discussion, but we should keep it in the back of our mind that these adolescents, they deserve screening for HIV, HBsAg and SCV also, because these viral infections may also get transmitted through sex. And advising them safe sex is very, very important. Yes, ma'am.
And Anita, Dr. Anita, I will agree with you. This is an opportunity also to, when you are investigating overall, then you can easily approach for these investigations, HIV, HCV, HBV, because otherwise they might become conscious. So this is, in general, you can take up. So that's a very important thing.
Optimization optimization of health conditions is also important, because whenever adolescent is come, we are looking at the adolescent in a whole whole health has to be taken into consideration. So that is a very good opportunity.
Yeah. So just give us a brief. Very, very brief about just touch upon those syndromic kits, the kits which you have to take because we have to consider the time also. Yes.
So WHO has, given these guidelines for syndromic management. These color coded, these kits are available. They are provided through NACO, National AIDS Control Organization. The centers, the HIV counseling centers in all the healthcare facilities, wherever there is a screening mechanism exists, like we have Suraksha clinics in our hospitals. It is, focused clinic for STI screening. Then we have HIV counselor room also, where screening is done with pre-test and post-test counseling. And if we are not able to get NAT test done, as usual in all the government facilities, we are giving these couples the syndromic management, like for urethral discharge or cervical discharge. If you can't get, even sometimes they will refuse examination, you can provide them with gray kit. If the patient is presenting with vaginal discharge, you give them green kit, and you can treat the partner also along with that. Similarly, if the boys are coming with other, like, I'm not talking in detail, like inguinal BIBO is there, then you have to treat the male adolescent also, ulcer disease, then you have the orange kit, then ulcer disease. So you have color coded. You can paste this poster in your counseling rooms, in your OPD rooms, and these are very, very easy to administer, and they are readily available in all the Suraksha clinics or STI clinics of those particular hospitals.
Yes, very nicely you have pointed out this. So, Pavika, will you take up the further?
Ma'am, can I add one line over here?
Yes, Dr. Neeta.
Amrit ma'am.
Dr. Amrit.
Dr. Amrit. Yes,
Yeah.
yes.
Ma'am, these are the syndromic approach that we are using currently. But the latest CDC guideline, they have little bit advanced over it, like for chlamydia, they are giving the first line treatment as tablet doxycycline 100 milligram for 7 days. They say the RCTs, they say the studies they have shown that it's better than the azithromycin single dose. But when the compliance is in, we do not like the patient may not take it, then we give azithromycin 1 gram. And similarly for gonorrhea, and because of the resistance, they are moving on to the other drug. Like they are moving on from cefixime to ceftriaxone single dose 500 milligram. These are the recent. No doubt this is relevant in our situation, but we must know the latest what is recommended by CDC.
Yes, madam. Yes, madam. So, Pavika?
Yes, ma'am. So this question goes to Ragini Agarwal, ma'am. Now, how will you treat this case, this particular case?
ट्रीटमेंट हो गया है, ट्रीटमेंट में बचा के
Yes,
आया.
ma'am.
So basically, the two things I want to say at this time, before treatment, just jumping to the syndromic approach for every patient, specifically in the private practice when we talk about, at least we have to diagnose, try to diagnose it. And as Dr. Mala Srivastava has said, cervical swab or rectal swab, for those things we have to go, and many a time everywhere NAT is not available. So we can send for the gram, at least for the gram staining and the culture to know the susceptibility of the drugs. And as immediately before this question, one of the panelists has beautifully answered that the guideline has little bit changed. One, that doxycycline, our own gynec for very, very favorite drug, we have to give it twice a day for 7 days, or azithromycin that we can give in a pregnancy also. And the second thing is in gonorrhea specifically, what I always prefer, because I'm not very sure how many medicines she's going or not. It's a wonderful to give a 500 milligram IM ceftriaxone injection once, but somehow the dual therapy is more coming because of the resistance, because of the reinfection, or gonorrhea is very notorious because it leads to a systemic infection and it reappear. So I think initially Mala has said this thing that we call again after 3 months these patients. So these patients can go for a dual therapy along with the ceftriaxone. We can give them the azithromycin. And one small thing, always when we have this patient, we should not lose the window of opportunity for one thing, to tell them use condom, and use condom.
Very rightly. So, Dr. Ragini, in fact, you said, but you added so many new points to it. And if with your level of experience, that individual thing also, management becomes of this case very important. And as this case was showing the chlamydia and gonorrhea, so your treatment, as you said, is very correct. So now, very rapidly, I would like from Dr. Amrit, Madam, that what are the 5 P's, because the audience also have to know it, besides all of our experts, that what are the 5 P's in the approach of the STI?
Yes, ma'am. The 5 P's are basically for taking a detailed sexual history of a patient when he or she comes to us. And the first and the foremost is the partners. We have to ask Like we have to go stepwise, not straightway jump onto the partner. Slowly we have to make a like rapport with the patient. Only then we'll start these things to like we'll ask after some time developing a rapport with the patient. So partners, we will have to ask what is the like gender of the partners, like whether it's male or female or some transgender person, whether having multiple partners or single partners. And the second P is the what practices they are using, like which type of sex they are doing, like it's oral, it's vaginal, or it's anal sex. And with the use of contraception, like barrier contraception or not. And then the third P is the protection from STIs, whether they are aware from these, like these STIs, they occur from the sexual contact. If they are aware, then are they getting tested from any doctor or any site? And past history of STIs, like past anytime he has been or she has been diagnosed with STIs or having got treated for that, and it's worrying him. And finally, whether what is the intention of the pregnancy, whether the couple, the partner, they want future children, and if they want, it's okay. If they do not want, they have to take precautions. So to go along by these five P's while taking a detailed sexual history, this will give us the risk, how much risk that person is carrying, and how much protection that accordingly we can manage this patient.
Yeah, so basically the most important things in this becomes now, like you have 5 P's, so you remember, you don't miss out anything. Yeah. That's the very important thing. Dr. Bhavika, you continue.
Yes, ma'am. Is Meenu Vash ma'am is there, or if she's not there?
No, she's not there. So someone next person can.
So someone can take this question. What does one-stop shop mean? Anybody?
Can I take that, ma'am?
Yes.
Yeah,
Yes.
one-stop shop or one-stop center means it is all the services are being provided under one roof. So, you know, adolescents as such are very shy to come to clinical establishments. But if he or she gathers that, courage to go to a clinician, all the services should be provided under one roof. Like the counselor should be there, the psychiatrist should be there, STI counselor should be there, the lab facility should be around, so that, the adolescent does not have to rotate here and there, because they need a lot of privacy, they need a lot of confidentiality. They usually have not shared these problems with their parents or their close relatives. So they just want privacy. And if we are going to provide them all the services under one roof, it will be very adolescent friendly. So that was the concept of starting these one-stop shops for these adolescents, as adolescents focused.
Yeah, so rapidly we go to the other person. Dr. Mala, would you like to tell us what services do gum clinics offer, and actually what is the difference between one-stop and gum clinic?
Medicine. Gum clinic means genitourinary medicine, and for the gum clinic, the adolescent and young people are welcome. They need not come with their parents. They can come alone. They offer testing and treatment for STIs. They give advice. During the gum clinic, you get the advice and information about sexual health. They provide free condoms, advice regarding contraception, also emergency contraception. And they also provide emergency contraceptive pill. Pregnancy testing is there, HIV testing is there. There is a scope for post-exposure prophylaxis that can help people from developing HIV if they have been exposed. Then hepatitis B vaccination. They also help sexual assault survivors, and if necessary, refer to a specialist. And they keep the record very confidential. They do not share with either their parents or their friends or anybody else. They also provide advice regarding abortions and help for sexually assaulted. So this is a gum clinic, which is a comprehensive clinic, where, as Dr. Anita said, one-stop clinic. for all the purposes.
As I think all experts were pointing out one or other thing, here comes that thing, everything, that HIV counseling part, the how to help these sexually assault persons. So all those points which by now they were going through every expert's mind, they are covered here. That's a very, very important thing. So Dr. Pavika, go ahead.
Yes, ma'am. Yes, Meeta Gupta ma'am can take this question. What are the 5 WHO goals for STI prevention? What are the WHO goals for STI prevention?
Thank you, Pavika. WHO has made some goals with the intention to, finally make this sexually transmitted disease not a major public health hazard for the entire global. So with this, they had taken 5 things into consideration. They had planned that 2018 as the baseline. So the next, by 2030, there should be a 90% reduction of Tripona pallidum as well as gonorrhea. And they have said that HPV vaccine should be integrated in the national programs of nearly more than 80% of the countries. And so this will take care of your gonorrhea, Treponema pallidum, as well as HPV, accounting to nearly 90%. The remaining thing was syphilis. So they said that the cases of congenital syphilis would be decreased. As a result, your chances of syphilis at the whole global incidence would also be decreased. This was the aim, so that the vision was of WHO that the entire STD should be, finished in this
2030.
Yes, 2030, ma'am.
Very rightly, Dr. Meeta, you have said everything. Just just an opportunity to mention here is that you all know nanovalent, the HPV vaccine has come. So that is very important because it is covering almost so we get this opportunity to counsel them about that also, that it is preventing almost 7 cancers. And another one thing which very recently in the April, there was a meeting at the World WHO level in which they are thinking of advising even that 1 dose might be sufficient, because probably only after that 90% national coverage is possible. So I thought to point it out here that even those are in the pipeline to come in the next few days.
And we are going to come out with indigenous HPV vaccine also soon.
Yes,
the company which was making COVID vaccine for India, so quickly they developed and distributed. They are coming up with HPV vaccination. So I think it will be good for our adolescents.
Yes, and
more
Dr.
coverage
Rita,
of
probably now the world after the COVID has recognized the India's capacity of developing the vaccine. So we should be proud of it, that we are, as you rightly said. Pavika, please go ahead.
Yes, ma'am. Anita ma'am can take this question. What is comprehensive sexual education and how it should be done?
Yes, comprehensive sexual education will deal with all aspects that have to be counseled. You have to be a very, very good counselors, which usually all gynecologists are. Your counseling skills have to be, brushed. You have to use gather approach. You have to use heads assessment. So you take a detailed history, see their even socio-economic aspects we have to take care, why they are indulging in sex and where they are, what is the history of partner, how many partners the partners I have already highlighted. 5 P's we have to use. All these things have to be taken into consideration while taking the history, and accordingly you have to do their cognitive, emotional assessment along with their physical examination, and socio-cultural I have already discussed.
I think
you have to give age appropriate education. Like if a 9-year-old is
education part, where do you want to give it? And those points, please. I mean, history examination we have discussed.
Start in the schools also, man. Schools,
that is what
school
is the
health education,
right,
wherever means
the
you
anatomy,
cannot
physiology, and the
opportunity.
How the birth occurs.
Opportunity is always there.
Dr. Pandey, time to wind up. Time to wind up.
Ma'am.
Okay, Dr. Sharda, we'll finish up. So that is what I was saying. So just let's, Dr. Ragini, what are the common consequences? Let's be just point-wise quickly so that we can finish. name.
Dr.
Just
Kiran, this question is can only be answered like this, that whenever we go for anywhere, this equally should be always in our mind. And when we talk to our adolescent, what is the sequely? What I used to tell them, there's two things जो चुपचाप आपकी जिंदगी में आती हैं, आपको मालूम नहीं पड़ता है. एक है प्रेगनेंसी और दूसरा है sexual transmitted infections. And we all know that pregnancy in a teenage girl can lead to the unsafe abortions also. And this STI can lead to the infertility, pelvic inflammatory diseases. So we have to be very, very careful to always take this window of opportunity to tell them about these sequelae also.
Yes, I will take very short because Dr. Sharda has said that. So contraceptive, Dr. Mala just point out a little bit, which are the best contraceptives you think of?
Best is to advise them condoms. But the problem with condom is there's a failure rate of 18%. LARC is good for the adolescent because we can advise them LARC, and there's no point in withholding LARC from our adolescent girl who are in regular relationship. But we have to tell these girls that with LARC, there is a chance of STIs as well. So even if they are using LARC as a contraception, which is a very good contraception, they should use condom to prevent themselves to save themselves from STIs. So dual use LARC as well as condom.
Okay. So just Dr. Meeta, Raj,
use of intrauterine devices. The myths are there with service providers that intrauterine devices cannot be inserted. We can very well offer these adolescents.
Yes, we can use
contraindication of any contraception method.
Yes, so that into the long acting also actually they become a part of it. So
just one line, ma'am.
Yes,
we can always advise a dual method. Like if they are using condom, because of the typical use failure rate is high, up to 18%, we can give them a EC pill course with them in advance. We can give them.
Can I just butt in? Can I just
Dr.
butt in one
Ragini,
line?
I wanted to bring it to you also also discuss HEDES assessment. In short, because we have
so okay. It's a very important to discuss the HEDES, and Kiran, we should not confuse this HEAD triple S with HEAD triple SED, because it is very different. When we talk about the HEDES assessment, it is an internationally recognized tool used to structure the assessment of an adolescent patient. When we are talking about the ED, it is a mental screening tool in the emergency department, and it has 3 values. So we should not confuse here. HEADSS is a home, education, employment, activities, drugs, sex and relationship. And these last 2 S's added here instead of the ED is self-harm and depression and safety and abuse. The most important thing is that when you talk about to an adolescent, you have to build a rapport, because it is not easy to them to be open to you. And you have to tell them that a confidentiality factor is very important for them. And the second thing which I want to add is my journey for the adolescent, which started with the 2006, when the first time the India has brought the ASHRH, and we learned one word, non-judgmental attitude, and not to talk to them like children. So when you're talking about the HEDES assessment, you take them as an individual, as a patient. Your attitude should be totally non-judgmental. Only then they are open about their relationship, their sexual behavior. And this is very important to discuss to find out whether they are getting some sexual abuse or any other thing. So you have to start your conversation from the smaller question, build a rapport, go in the deep, from the home to education to activities to drugs, smoking, alcohol. That is a very, very important thing to talk to them. And actually, the main thing which we want to see about their depressions and the self-image quotient and other type of abuse. Just to summarize in one line, It does not necessarily have to be completed in one sitting. It may take multiple conversations to build up the trust for the young person.
Very good. That is what I was
say.
focusing. More great rapport has to be developed again and again. Lots of confidence. Before I take the final word, just Meeta, one word about Rashtriya Kishore Swasthya Karyakram, and then we take the final opinion.
This is one of the schemes that has been launched by the Ministry of Health and Family Welfare with the basic, because of this changing trends of the newer adolescents. This was the newer integration they had launched in 2014. They wanted to look into the sexual health of the patient, the adolescent health. Basically, adolescents have the basis of this program, and the entire aspects, the anemia, the sexual health, the nutritional aspect, the education, everything is taken into this thing, ma'am. So this was...
Yeah. And more, madam, I just want to add one line that RMNCH program was there. That was regarding reproductive and maternal health. Now it has become A. Now we know the importance of adolescent health. So it has become RMNCH plus A. So that is also very
correct. Very correct. So now just one word from each, not the detail. How do you think, the last question is this, from every panelist should give their one-line answer. How do you think that we gynecologists can promote adolescent health? So that is the final thing. I want everybody to add up something to us. How do we?
So, ma'am, counseling, only counseling.
Cream.
Okay. We should not miss any chance whenever we get in communication with our students. Use that time
from my side,
education of the comprehensive sexual health education. That is the most
only thing I can say, the window of opportunity. Always remember, adolescent health is not something that you are going to give to an adolescent, because most of the time no adolescent is going to come. Maybe that adolescent has come with a mother, or that mother has come for something else. So this window of opportunity should be used for the promotion of the adolescent health in the community and everywhere.
And every clinician should be a very good observer. Whenever you are dealing with an adolescent patient, get those subtle clues that the adolescent wants to share, because there may be 2-3 patients standing around you. So give them opportunity, give them privacy, give them share that their conversation will be kept confidential. So those,
and basically non-judgmental environment.
Yeah, we have to be very good observer. Yes.
Yes. So ensuring privacy, non-judgmental environment has to be created. Yes, Dr. Mala, you want to give
we have to be non-judgmental. We should not give them advices. Don't do this, don't do that. They have come to us. They have come for treatment. They have come for... So we have to respect them. Give a lot of respect to them, because it's good that they have come to a gynecologist and not gone to a quack. So we have to take this opportunity, listen to them patiently, treat them, and definitely take an opportunity of window of opportunity to guide them.
Yeah, thank you very much, Dr. Mala. What I wanted to say, the most important thing, changing our attitude. Also, even today, most of the gynecologists in general will start saying, with this, don't do this, and why you have done this. So we have to be non-judgmental, respect their things, and at the same time, with gaining the confidence, then explaining them what are the side effects or what are the problems can they go into, and then only we can give them this. So thank you very much.
One important point we are forgetting. It is okay that these girls or boys that are coming to us, they're sharing the problems. Very subtly, we have to, apprise them of our existing law of land. We need to, apprise them about PCOS also. We cannot deny them services, but we have to very gently tell them that, currently we are living in India and sex before 18 is illegal. So we cannot be directive. We have to just give suggestions. Yes.
About that, we will discuss about PCOS, but then I thought, let's keep
Just
it
a line, yes.
respect the time limit also and the other things. So therefore, I thought let POXO is a different aspect, but of course, you have to keep it in mind. Very rightly pointed out, and very much. So I really admire everybody's view, concern for the adolescents. And the most the important, I would again say, Dr. Sharda Jain, Dr. Sadhna, Dr. Ragini, and everyone to give us this opportunity to be the part of this academic series. Dr. Pavika, who has actually worked a lot hard on this, because I is not in India, so I could not do much. She has taken. Dr. Pavika, thank you very
Yes,
much.
ma'am. Thank you so much, ma'am. Thank you. Thank you.
Thank you. So all my panelists have given their expert views, and you have enriched our knowledge also. So now let's go for experts. They
Kiran
would
ma'am,
like to
thank you
comment
so much.
anything.
Ma'am, Kiran ma'am, just on the behalf of us, the panelists, we want to thank both the moderators. Both of you, you have really brought us the expert comments from everybody. Thank you so much, ma'am. Thank you, ma'am.
Thank you, Dr.
Thank you, Pavika.
Really.
Dr. Kiran, Dr.
Madam, stop sharing, please.
Yes,
Yeah,
ma'am. Yes,
okay.
ma'am.
So I think, Madam, you would like to give some expert comments, enrich us with the further knowledge, or our experts of this. Are there any experts in the panel also?
I will say, adolescent health is very dear to my heart. And I started it at a time when there were no experts on adolescent health was available. I got an opportunity of train hundreds and hundreds of doctors in adolescent health through IMA. And I feel, this is what is needed. I have a little difference of opinion when you talk about heart and putting an IUCD. It means you have never worked. You're only talking practical. You are talking theory. आप मुझे अपने प्रैक्टिस में बताइए किसी बंदे को आपने IUCD लगाया? हम फ्रांस नहीं है, हमें हिंदुस्तान की बात करनी है. और every time my request to everybody is every academic session must be timed, and everybody should finish at that particular time. When you're in a panel discussion, when you're talking about it, when your turn comes, you should speak. If you increase your comments like this, then you will find that your time will definitely spread and we go beyond time. So my request to future panel is that be in time, and we must talk. We are in India, we must talk about India. People like us are pioneers in adolescent health who have conducted workshops in medical college, engineering college, Delhi colleges, everywhere we had gone. And we know what the practical part is. If you're not practical, if you don't give life advices to them and do a courses, things of this particular kind is not possible. इतनी बड़ी पैनल थी, मुझे बताइए किसने किसी ने IUCD लगाया है? बोल रहे हैं हम लोग.
Patients are asking for it now. The girls are coming and asking for it.
Patients are asking. The girls are coming and asking.
Because they come, they Google and they come with the knowledge and they come and ask for it.
Even, ma'am, I had Asha gathering yesterday.
डॉक्टर साहब मेरे को अपना डेटा दिखाइए, अपना डेटा दिखाइए, आपने कितना किया है?
Of course, ma'am. Those, even ASHA workers were asking. Yesterday we had a meeting. They said, can it be inserted? Because somebody might have asked them also. So I was just giving a reference that it is a myth that it cannot be inserted in a sexually active adolescent. That's what I wanted to
lies there. As a gynecologist, we cannot say that you use this thing. Counseling is okay, but if you are putting a Mirena or something IUCD, you are saying that yes, you can go and have a sex. That is equivalent to a rape if a girl is less than 18 years in India.
Yes.
So we have to be very careful what we are doing and what.
Very true. Very true.
डॉक्टर साहब मैं आपको बताना चाहती हूँ, I remain chairman of Max Hospital. मैंने एक पेशेंट का एडोलेसेंट का एक यूरिन प्रेगनेंसी टेस्ट करा दिया, तो उसका जो फादर बैठा हुआ था, he went to the CO and said Dr. Jain has asked for a urine pregnancy test. We are working in those times, so be practical what you're talking about.
Madam,
So the discussion had been absolutely great. I will say that the panel was absolutely wonderful, and less is said about the madam's presentation on adolescent PCOS. I think it was just wonderful.
Thank
Just
you very
wonderful.
much, madam.
Dr.
And
Padre,
your
thank you very much.
pearls of
And you
wisdom
know,
are very important for us.
Thank you so much, ma'am. Thank you, Dr. Shada Jain, ma'am, for your final comments. And I am sure next time we will be very brief and to the point and up to the time. So that we have to keep in mind for our next webinar. And over to Dr. Meenakshi Sharma for the vote of thanks.
Thank you, ma'am. The world is full of diamonds and gems, and we are having some of them today in our first successful meeting of North India Gynecologist Forum. Respected Dr. Sharda Jain ma'am, Dr. Sadhana Gupta ma'am, and Dr. Ragini Agarwal ma'am, and all the stalwarts and dignitaries who are present here today in the meeting. I really feel honored and privileged to propose this vote of thanks on behalf of N.I.G.F. I express my gratitude and sincere thanks to all the experts today for a very informative and successful academic session today. And I would like to thank all the known and unknown hands that contributed for the success of today's program. And a big thank you to Team COR Connect for providing the platform for the meeting. A good event never ends in the world. They take only a pause and keep us awaiting for the next. So our next meeting is going to be on 3rd Friday of this month. We are all happy and grateful for this successful program today and hope and wish for success of our newly formed organization. And on this platform, I want to say that please, I'm requesting every one of you to please circulate the form, which is available online link or to the Google form for the membership of the North India Gynecologist Forum. So please circulate among all your friends, all your professional groups, so that we get more number of members in our organization. Today, as of now, we have around 450 members who have filled the online form. And more than 150 are from Delhi and the rest are from other states. I can give you the breakup also. But I just request everyone so that by the end of, by the time of the next meeting, we have more number of members and we achieve a target of 2,000 members by in the next 2 weeks at least. Thank you. Thank you.
Please mark the date 5th August. We are going to have our next program on the 5th August.
That's right. Good.
Thank you. Thank you very much,
Thank you.
madam.
Thank you. Thank you.
Thank you.
Dr. Malik, Dr. Malik, for you. When you are a moderator, you have to see to it that you will keep things to the time. I should not be speaking next time.
Yes, madam.
Thank you, ma'am. Thank you, ma'am. Thank you so much, everyone.
Thank you.
Bye-bye.
Great.
Bye.
Thank
Bye. Thank you, everyone. Thank you. Thank you, Sadhana ji.
Nice
All the
weekend.
best. Congratulations.
Dr. Kiran Pandey, thank you very much. I think it was very absorbing.
Very
Thank you, madam. Thank you, madam. Sorry, I apologize on behalf of all my panel for taking few minutes more.
आपको करने की जरूरत ही नहीं, डॉक्टर साहब. People went overboard. That's all.
Thank you, madam.
Thank you, man.